studio for this episode 1 of the Unbroken Care and Handling of Endoscopes series. This is episode 1, and we're starting kind of at the beginning. This is a circular process, so you could start anywhere you wanted to start in the process. We're going to start the conversation today in episode 1 on scope treatment triumphs, overcoming obstacles at the point of use. And we got a great lineup today in studio with us. We're going to go around the horn for some introductions, but we're going to be hearing today from Garett Kaple, from Joanne Lee, and from Minion. But we're going to start the introductions with Joanne Lee. So what's your story, Joanne? And let me start and just say welcome to the show today.
Thank you very much. I feel very welcome. Joanne Lee. I am a certified surgical technologist for now over 13 years. I also teach the program at Pima Medical Institute.
Wonderful. We love talking to teachers and educators on these various podcast series. Obviously, that's the spirit of this conversation today. So we got a great educator in studio with us here in Joanne. Let's go next to Garett. What's your story here? Why are you in here talking about endoscopes with us today?
Thank you again for having me today. My name is Garett Kaple. I'm the marketing manager for reprocessing at Richard Wolf. And I'm here to have a conversation about point of use and learn and help add where I can.
All right. Welcome, Garett. And then rounding it out, Katie, it's a pleasure to have you. You're also, you got some education in your job title, in your role. So I'm going to put you and Joanne probably in the same category here as our professors and teachers, and me and Garett kind of be on the other side. Just ask a bunch of good questions, right?
Yes, definitely. So my name is Minion. I'm a senior clinical specialist at Richard Wolf. As Hank said, we deal a lot with education. So I'm here to, like Garett, add in and maybe even learn a little bit more myself about some point of use in the sterile processing department.
Yeah, that's a great point. Every time anyone has these conversations of point of use, especially because this industry and these guidelines are constantly changing, I learn things. If you listen closely, you're going to learn something. You're going to be challenged in your best practice or your practice that's going on today in your facility. And so let's just start here, Joanne, at the very beginning. When we say point of use, there are certain things that come to mind depending on how you've been trained or where you've been trained or what you're doing. But let's just set it at the very baseline level, at the foundational knowledge. What do we mean when we say point of use treatment? Can you give us a quick overview?
Point of use to me as a certified surgical technologist is what do we do with the scope, with the endoscope after a case is done? Not when it's being sent down to be reprocessed, but in the operating room. What do we do? Well, the main thing is to prevent organic debris from solidifying. So as the surgical tech, we have to do a pre-cleaning. So that's my definition of point of use.
So I kind of alluded to earlier some of the standards or the guidelines out there. So if you were to orient your students to this practice, this point of use practice, and they say, yeah, but why? You just gave one good example. Why? Because we don't want these solids in this matter, to be, again, sticking to the device. But what's the other why from the regulatory side? What do the books, the textbooks, the guidelines say?
To prevent infection. To prevent illnesses, to prevent deaths, practicing safety for our patients, and to take care of our instrumentation.
And so what I'm hearing from you, and I guess what your response again would be to students in training, is not, hey, this is a preference. This is Joanne's preference. This is kind of how I want it done in my operating room. But really what we're responding to is an industry expectation that's higher than the instructor, that's higher than the perioperative manager and director, that actually is the umbrella over all of these practices across the U.S. that says, no, point of use treatment is something that must be done every time in every device.
Absolutely. That is correct.
So let's talk a little bit about why it's such a big deal on the provider side in the room. when we're talking about surgical techs and we're talking about nurses that are now completing this case, why is point of use sometimes pushed back against or seen as, hey, I've done everything else in this case, right? We've cared for the patient. And now you're asking me to do one more thing. How do we navigate that conversation? How do you communicate that?
So how we navigate this additional step, because I remember a time when we didn't have to do this, is centering it back on patient safety. What if that patient was a family member, a loved one? Do you want a malfunction instrumentation used on that patient? Absolutely not. It comes down to it's your responsibility, regardless how many additional steps it takes.
We've talked a little bit here, Joanne, about the high level, what this means, why it's important, but I do want to get down maybe to more specifics in the process itself. So what does this look like if you were just an observer in the corner of the room, the case is done, the scope is ready for this pre-treatment phase? What's going to happen? What am I going to see happening in front of me, or what should I see?
What you'll see me doing is grabbing a kit that we use, and it's a small little container, plastic container. And what comes with it is a sponge that has detergent in the sponge already. I grab a empty syringe. I fill the tub with sterile water along with the syringe of sterile water. I activate this sponge by squeezing it multiple times, and you'll see the suds appear. And what I do is I would flush the cystoscope with the syringe filled with water and with the detergent 3 times. With the sponge, I clean the handle of the scope along with the shaft. I then discard the sud-filled water, the detergent-filled water, replace it with just regular sterile water, and rinse off any of the detergent, flush the scope out with the sterile water 3 times. And then it's ready to be sent to sterile processing for high-level disinfection.
And so, Katie, what Joanne just described from memory, by the way, is her practice in pre-treating these scopes. But, what she's also describing is a very highly regulated step-by-step process that's found in these device IFUs. And I'm curious if you can speak to that on the training side. Obviously, some of these IFUs will differ from device to device on, what is required or what the expectation is for this point of use treatment. So when you're out there educating device users, how do you approach that nuance to hardwire the high level process, but then also ensure that there's an awareness of the differentiation depending on the device that's being used and what that IFU is requiring from the provider?
When we go into facilities and are educating them, like you had mentioned, the IFU is kind of our guide to the cleaning process, right? So if you kind of think about it in the sense of another item that you have that has instructions for use, an IFU or a manual, you could call it, to preserve that item or to get the most use out of it or to make sure that it is being used appropriately, you follow that manual, right? So we really enforce following that manual, that IFU, to make sure that those cleaning steps, like the point of use cleaning that Joanne had mentioned, is being done.
Garett, to bring you in on this, Katie brought up the point of training, and you got this instruction guide that's kind of like the Bible of the device. And yet, like we were speaking to Joanne earlier, there's still a challenge in communicating the value and the expectation of this pre-treatment phase. So I'm kind of curious, in your experience out there, what are those common excuses, maybe we'll call them, or what are the common reasons that we see where folks tend to not do either any pre-treatment at all or not do this compliant pre-treatment process that Joanne and Katie have been sharing with us?
Sure. So from my experiences, I've noticed all facilities are doing some sort of pre-cleaning or point of use cleaning, which is great. And different facilities have different standards, but all of them pretty much use the IFU to follow the steps needed in cleaning. And one thing I've noticed in particular with flexible scopes too is the way that they're using Joanne had mentioned the enzymatic sponge that she uses at her facility. When those are used on flexibles, there's a certain method almost to help prevent scope damage when you're cleaning, because the distal tip is very fragile on a flexible scope. And certain methods like that different facilities use, I think is unique as well. So yeah, from what I've noticed, point of use is super important to facilities and also care and handling.
I'd like to add on to the challenges that I face in the OR. And one of them is turnover. Turnover is when we move on from one case to the next. And in every facility that I've worked at, turnover must be fast.
So no, you got plenty of time, Joanne, right? There's always a lot of time to do the turnovers.
And so I believe that teamwork is super important. Your nurse, your circulating nurse has to be on your side to not rush this process, because really it just takes about 3-4 minutes. And yes, in operating room time, that's a long time, especially for turnover. But where I work at Overlake Hospital, we're all pretty much on the same page. And don't get me wrong, we started this several years ago, and we've hit some bumps along the way. And even in current times with the staffing crisis, where we have new staff / travelers, trying to get everyone on board with this requires teamwork.
Yeah, Joanne, you bring up a good point, and I want to maybe follow up here with another question on that teamwork piece, because when I'm out there talking to teams around point of use, and one of the pushbacks that I hear, this is kind of a cultural pushback, maybe also a training pushback, is, hey, cleaning and stuff, that's not our job in the operating room. That's sterile processing's job. And in your first answer, actually, I think to the first question I asked, you kind of dispel that myth completely and said, hey, this pre-treatment conversation is not what happens in sterile processing. This is what happens at the point of use. And so how do you speak to that in facilities or maybe with your students who are like, hey, our job is, patient care. Their job is device management. So let's just cut out that 3 or 4 minutes you just mentioned and just go ahead and send this device so they can get that process started. How do you kind of speak to that?
Well, the beauty of being an instructor is teach them young, teach them while they're still fresh. And daily, I remind them that decontamination starts in the operating room. As for out in the field, yeah, it's a little more of a struggle. When I teach new students or new hires, I try to drill that because I'm passionate about it. I was a sterile processing supervisor for some time during my 13 years as a certified surgical technologist. And I see the importance of point of use, that care, because it makes everybody's job easier. And it's just all beneficial for the patient.
And so, Garett, we've been talking a lot about process in the OR. We've been talking about teamwork that Joanne mentioned, but I also want to speak briefly here about the life of the device. I think you even brought it up, the pre-treatment process that Joanne mentioned. If we're not careful, there's opportunity to damage the distal tip, for instance. But at a high level, a lot of this pre-treatment is also device management as much as it is, patient safety and infection prevention. So can you talk just to the value of that in the life of the device if teams are not adequately or properly doing the pre-treatment phase every single case?
Yeah, I think the first thing that comes to mind is making sure you're not only following the appropriate steps in cleaning, but doing them correctly. And I think that's going to elongate the life of the device, making sure you're cleaning all the ports appropriately, flushing appropriately. In addition to transport, I mean, when you're transporting from the OR to the SBD, a lot of hands touch the device. So even the tray or case that you're carrying the device in matters. So yeah, it's super important, like I said, not only making sure you're doing all of the steps within the IFU, but doing them correctly.
Joanne, you mentioned that you're in a facility that has kind of seen this process from creation into a period of kind of maintaining now this point of use treatment for scopes. For anyone who's tuning in who maybe doesn't have the tightest process or is struggling in some of the areas even that you mentioned, maybe they got travelers being onboarded, they got new technicians kind of coming in and they just don't really know where to start to get their arms around and begin to standardize a compliant pre-treatment process. What words of advice or what lessons learned would you want to share to that team to say, hey, don't give up, and here's a couple things that you can maybe do to get you started?
Okay, so Overlake Hospital, where I currently work at, we do have to provide Department of Health and other regulatory bodies a process to track compliances and fallouts. Therefore, it is a responsibility. It's more than just a responsibility. It's a requirement for us to pre-clean these scopes to keep our numbers accurate, to keep the infection rate low.
So, Katie, as we move close to the end of time for episode 1, and just for everyone who's listening, right, this is episode 1 of a 6-part series. So we're going to continue these scope-related questions now for a couple more episodes. But as we wrap this initial introduction and discussion of this scope treatment and this point of use treatment that we've been digging into from the compliance side, from the process side, from the training side, from the reporting side, as Joanne just kind of mentioned, what other insights or perspectives or what else have you seen out there in high performing facilities that you go into and you're like, okay, these guys got it going on. Everyone sees a vision and they're doing it. Is there any marks of success that you've seen that you'd want to share today?
So a couple things that I have seen in highly successful ORs is communication. And as Joanne mentioned, teamwork, everybody being on the same page of, wanting to achieve a common goal is key, I think. And then, like I mentioned, the organization, keeping track of, as Joanne mentioned, the infection rates and maybe scope damage rates, things like that can be tracked and monitored can go a long way when it comes to the point of use treatment in the OR.
Yeah, that scope damage comment is a great segue that's going to move us in to future episodes, because we're going to talk a lot about the damage piece, about the care and handling piece, obviously, which does come back to point of use. And I just want to call this out as we wrap this episode. But even if we've got the team set up, we've got great communication, got great training process, got great students that we're churning out that Joanne has trained for us, if the device itself is already damaged in some way, even compliant point of use treatment is not going to be able to do its job because of the device damage. And so this piece, this care and handling piece, does reoccur again and again and again. It helps us to reduce the damage if we're doing pre-treatment correctly. But again, if the device is already damaged in the rest of the process, then it's also not accomplishing its goal. So that's going to come up many times in the future episodes of this Unbroken series on care and handling of endoscopes. But today, guys, I want to thank you all for great insights on this point of use treatment. It's a big conversation, a lot of moving parts, but I think we really defined and outlined what the core mission of this is, which is pulling together for the device and the patient at the other end of this device. So scope treatment triumphs overcoming obstacles at the point of use. Great conversation today for episode 1 to kick us off. One of the big highlights, it came up again and again, was this conversation around communication. And it's really communication that comes from all corners. Like we hear communication, sometimes we put it right in the same category of teamwork, which is true because you're communicating to your team members in that scenario. But communication in this context is actually even broader than that. So we're talking about communication from the regulatory side of the world. We're talking about communication from standards and guidelines and training out of schools that are churning out our surgical techs, our sterile processing technicians, our nurses. We're talking about communication that's obviously coming from the manufacturer in the form of IFUs or in-services and trainings. All kinds of communication that's being directed at one focal point. And it's that really small stage, those 3 to 4 minutes that Joanne mentioned after the case, prior to transporting this device into the next stage of decontamination. It's this point of treatment. All this communication comes down to this one point. So not only what you should be doing from all those angles that I mentioned, but also if you see anything that shouldn't be there, any damage, or if you see any shortcuts being done, maybe from your team members due to stress and that constant pressure of turnover that we discussed in this episode, whatever it is, that's also a time to communicate those fallouts across the team, up and down and around, in order to ensure that every time this device is used in the operating room, it's pre-treated compliantly so that we protect the device and we protect the patient at the other end of it. I hope you enjoyed this first episode of this Unbroken Care and Handling of Endoscope series with Richard Wolf, and we can't wait to see you again next week.